Intervention, a concept that we can implement in autoimmune disease by Dr. Chandrashekara S. We are all familiar with him. Dr. Chandrashekara is one of the most eminent rheumatologists and immunologists in the state here. He did his MD in internal medicine in Mysore and DM in rheumatology at SGPGI Lucknow. He's been a professor of rheumatology at MS Ramaya Medical College, and he's been running his rheumatology center for several years now. All of you are familiar with him. So without taking too much of your time, I invite Dr. Chandrashekara to speak on early diagnosis and early intervention. Thank you.
Good morning. So this is the first talk. What I thought was, let's introduce to what is this early diagnosis, early treatment, and what are we talking about when it comes to autoimmune disease. See, as you are aware, in previous sessions we always used to say that we need to treat rheumatoid arthritis, we need to treat SLE, we need to treat vasculitis. And we always used to say that we need to confirm the diagnosis, we need to make a beginning after making the confirmation of the diagnosis. If you read the text little more earlier, we always used to say that if it's a rheumatoid arthritis, try first with pain relievers, then try with disease modifying anti-rheumatic drugs. Not finding benefit, go with an experimental medicines or experimental drugs. Conceptually, things are getting changed, getting better over, and over a period of time we are trying to think that that's not the right way to approach. Why are we so much worried? What are we really worried about this autoimmune disease? What's making us to so much focus? It's not just the lecture today here. It's all over the world. There is a talk, you see any internal medicine journal, they talk of early diagnosis. You see any other journals, we talk of early diagnosis of autoimmune disease. Does it really make a worth? See, it's fundamentally clear for all of us, whether it is an infectious disease, whether it is a malignancy, whether it is any other disease. Key to a success in any of the treatment is early diagnosis. Catch the disease early, you are more likely to do things much better to the patient than what late it happens to be. But we were questioning about the autoimmune disease. Does it really make sense? Does it really make any difference? Because the drugs we used to have, the drugs we used to treat with were more toxic, had more adverse reactions, more wrong things to do than what it happens to be. And in addition, we also know clearly that when it comes to tackling autoimmune disease, we have a lot of unmet needs. We know we are not able to do what we can really do. What do we mean by that? What we meant here is that if you look at the natural history of a disease, of an autoimmune disease, if you look into the way the autoimmune disease behaves, if you really treat aggressively, you do have seen an entity called remission occurs. In a sense, patient can go for a state of remission where the disease process frees. Unlike diabetes mellitus, where most of the occasions we may not find an end point, whereas we do see, if you come to rheumatoid arthritis, handle it early, you can see a remission. And we do have recorded in the natural history of the disease that the disease process goes to a state of remission. In a sense, remission in an autoimmune disease is an achievable state, unlike some of the metabolic diseases. So we know it can happen, but we are unable to achieve it. So that gives a huge bridge that we have a lot of unmet things which we could do, but which we are not able to do. So focusing on that, many studies have been done. We're trying to work out whether if we do it early, will things change? If we intervene early, will things change? And there are some evidences, there are some proof which clearly says, yes, if you do a job early, the things will become better. So you can achieve, or you can go for a state of remission, and the chance of achieving remission is very high. That has put us, or pushed us to think that we should do something early, we should find out a disease early, and we should try to treat these autoimmune disease as early as possible. So why in autoimmune disease? What really makes us to think? So I just put my argument because this is the way the world is thinking over. what makes and why does this early intervention makes a difference with reference to autoimmune disease. In first 10 minutes, I will tell the basic pathology, etiopathogenesis, how that process makes us to think that early intervention can help in autoimmune disease, and in the next half, the evidence that has been accumulated by the evidence-based medicine, how the proof to say that certainly the early interventions make a difference. See, if you look into the way the autoimmune disease pathogenesis or etiopathogenesis has been thought of is, there is a genetic susceptibility, and also there is a possible micro and macro environmental factor which influences the development of the disease. There is some triggering process, some sort of a initiating process which triggers autoimmune process, which is attempted by the body to correct and rectify because there is a mechanism of tolerance which is brought in. When this breakdown in tolerance occurs, the autoimmune disease starts up. The autoimmune disease process over a period of time matures and it becomes more and more aggressive, and the end organ damage and the disease develops. So if you look into the process, it can happen if you intervene much earlier, if you intervene much before the breakdown of tolerance occurs, you can really do a good job. Or even at least if you avoid the maturation of response to become much more worse, you will be definitely able to make a much more better job. So in a sense, fundamentally, if you look into the way the disease process occurs, if you intervene early, you would be likely to avoid the end organ damage, or if possible, even the process or disease process evaluation over a period of time, evolution into a much worse disease. See, one of the fundamentals of an immune system response is that immune system tries to mature. In a sense, let it be on an infective organism, even if it's on a virus or on a bacteria, what the immune system does is, it first identifies the antigen, one part of the or one portion of the pathogenic organism, then subsequently it tries to identify much more portion of the pathogenic organisms, and it increases and improvises the antibodies it is going to secrete. It gets higher affinity antibodies, it gets higher avidity antibodies, and it improves the way it is going to attack on these microorganisms, and subsequently retains a memory of this particular episode and tries to protect the organism for the rest of the life. The same thing does happen when an autoimmune process happens. In a sense, it first identifies a small portion of a self antigen, and subsequently it tries to identify few more portion of the antigen, and over a period of time it even increases the affinity, avidity, and various other proportions of the immune attacks, and that results in maturation of autoimmune disease. You get more number of autoantibodies, more diverse clinical features, and much more to happen. And there is a very good clinical observation that has been done, that if you look into, even if the people who have practiced over 3-4 decades, if you recollect, the amount of vasculitis as a complication, amount of interstitial lung disease as a complication, development of nodules and other complications are less common in the current rheumatoid arthritis patient. If you compare it to the older rheumatoid arthritis patients, the amount of vasculitis, amount of interstitial lung disease that is reported worldwide is much lesser after post era of disease modifying anti-rheumatic drug. The reason, one of the reason what we thought was probably rheumatoid arthritis is going milder, but that may not be the true reason. The true reason could be because the disease modifying anti-rheumatic diseases drugs are intervened early, and as a result of intervention of early, less of the maturation occurs, less of diversification of the disease process occurs. That could result in lesser intensity of the disease process. In addition to that, as the time progresses, more number of autoreactive cell clones appears. This is what really happens even in an infection. As the time progresses, if the infective organism doesn't go off, more number of T cells are recruited, more number of B cells are recruited. T cells which are recruited are going to amplify, B cells which are going to recruited are going to amplify. More number of macrophages get into the site. Same process occurs in autoimmune process, because antigen is a self antigen, antigen is present in much number and a much wider number. So obviously the stimulation goes on, and the more and more number of cells accumulate over a period of time. we do see that there is an establishment of PANAS, what happens in rheumatoid arthritis. Similarly, in other diseases, a locally invasive cellular aggregate happens. This results in more and more aggressive disease and more refractory disease. So in a sense, as you allow the time process to go through, the disease process becomes much and more and more established, resulting in the disease process to be more and more resistant to the treatment or therapeutic interventions. So just to recapitulate, see the disease process in a little tree manner. So as you are aware, it's a genetic and other susceptibility trait and environmental trigger factor. Say first developmental error. What I am trying to say is, first development of sort of an autoimmune phenomena or a reaction, body tries to go for a spontaneous correction through the peripheral tolerance mechanism. If it is achievable, it goes back to normal homeostasis. If that doesn't occur, a second error occurs, the error becomes more and more mature, still attempts to correct, but if it fails, then the entire disease process starts and the disease progression rolls down over a period of time. So if you intervene early, a rolling down process can be prevented much more earlier in the tree of rolling down. That in turn helps us in treating these patients much better. What is the evidence from the evidence-based medicine? So if you look into the randomized clinical trials of early intervention, if you look into the clinical studies of early interventions, we have an excellent evidence with reference to rheumatoid arthritis. There are more than 160 different early intervention studies which have happened comparing the early intervention versus late intervention with reference to rheumatoid arthritis. They have clearly shown that early aggressive disease modifying antirheumatic drug improves the remission, reduces the number of erosions and deformities, and also even as milder disease modifying antirheumatic drug like hydroxychloroquine, if it is introduced early in the course, prevents and improves the outcome. Extra-articular features are less common in this group of patients, and even the latest recommendation and guidelines have already incorporated this particular finding. All the recommendation, whether it's of ACR, EULAR or IRA, all these recommendations clearly now includes it as the moment you diagnose it is rheumatoid arthritis, start with disease modifying antirheumatic drugs. It's come out as a part and parcel of a recommendation for treating and handling rheumatoid arthritis. What about systemic lupus erythematosus? There are studies which have demonstrated that early therapy has a better outcome in rheumatoid arthritis, in systemic lupus erythematosus, and remission can be induced, or at least the amount of organ damage can be significantly reduced. But if you look for a search, if you put for a search of a real done randomized clinical trial with reference to systemic lupus erythematosus, neither Medline database or NBase database do not come up with any studies, because in a sense there is no randomized clinical trials wherein they have tried to work out with early intervention of a drug in systemic lupus erythematosus with late intervention of systemic lupus erythematosus. The reason could be ethical consideration, the reason could be the difficulty in making the diagnosis of systemic lupus erythematosus, and there are many more reasons why we are unable to work out much with this. But there are proposals to work on these particular studies and trials, and none of the current recommendation are still incorporated because there is no adequate randomized clinical trials. But at least currently there is a universal agreement without much evidence as a recommendation that you intervene as early as possible and as good as possible with reference to systemic lupus erythematosus. So we can just say the level of evidence is not really adequate, but we need to wait for that. When it comes to vasculitis, there are enough trials which shows that early diagnosis improves the outcome. The interventions even can reduce the number of renal as well as neurological diseases, and higher immunosuppression drugs like cyclophosphamide, rituximab helps in inducing remission in these group of patients. That we can say the moderate because number of trials available are less, but definitely the trials are less basically because it's relatively rare disease, not unlike rheumatoid arthritis where more number of trials can be done at a wish of the trial, because vasculitis per se being less common disease compared to rheumatoid arthritis, we need to wait for few more studies to crop up. With reference to ankylosing spondylitis and seronegative spondyloarthropathies, currently we are not really seriously working on whether we should intervene early or not. There is no trial, there is no adequate evidence or no specific recommendation which says we need to intervene early. Here we still go with the old protocol of start with NSAID, no response, give sulfasalazine, no response, go to anti-TNF drugs. So in a sense, with reference to these group of diseases, we don't have evidence or we don't have much more work to do. But there are a lot more work which needs with reference to this. So what's the real barrier in detecting these autoimmune diseases early? The most critical is the patient's factor. Usually patient refuses to accept this kind of diagnosis, or patient, if he feels there is an arthritis or joint disease, tends to ignore it, or he tries to go for an alternative therapies much before he approaches a modern clinical care, because there is a myth around the patient's community that nothing much can be done with reference to these arthritis and related autoimmune disease by the modern clinical care. The second barrier is from our side, the physician side, because we sometimes miss in identifying this disease. When a patient walks with a joint pain, we have a limitation sometimes to do the test, we have a limitation to think of a probabilities, and we first primarily we think of infectious disease or other diseases as the first diagnosis, try to reconsider the autoimmune disease as the next possibilities, and usually we do see sometime that the patient has been treated in 2 or 3 occasions for typhoid, tuberculosis, etc., and finally in the 3rd or 4th admission to consider a possibility of systemic lupus erythematosus. There is a lot more barrier from our side in identifying the disease. The reason probably could be that we think that nothing much can be done to this disease, because once you call it as SLE, nothing much can be done. If it is called as a rheumatoid or something else, nothing much can be done. Probably that feeling of frustration may also be becoming a barrier for us to make up a diagnosis of an autoimmune disease. So certainly we do sometimes fail to identify an autoimmune disease early in the course of the disease. And obviously that results in the referral failure or failure to initiate an appropriate treatment. This have both patients and physicians barrier, because this is a combined factor. We do sometimes put a stop by ourselves that not to treat it. Patient himself defer to get treated. So these are the other barriers. And in addition, the policy and healthcare system is not much emphasizing with reference to autoimmune disease. If you look into any insurance, they flatly refuse if you make a diagnosis of rheumatoid arthritis. If you talk of a systemic lupus erythematosus, first time he approves, second time totally he disapproves the insurance and insurance coverage. Similarly, the government policies don't much envisage or doesn't much emphasize on the research, treatment, identification of autoimmune disease. All over the world, it's been recognized that this is going to be one of the major health problems. It's one of the 3rd in list or 4th in list in among the non-communicable diseases, which is going to be one of the major burden over a period of time. But not much more emphasis is done both by healthcare providers, and there are various other socio-economic factors which interferes in going ahead with this early detection and treatment. We need to get over all these barriers. Probably this particular session is a little smaller effort in taking first and second barriers. So with this, what corrective measures we can do with reference to this? One is improvising the awareness of autoimmune disease to both the patients as well as to the doctors, and improvising the referral practices and guidelines, because a lot of referral guidelines have come when exactly the patient should be suspected of rheumatoid arthritis. For that matter, one of the article has gone to the extent of saying if there is a squeeze pain of the metacarpophalangeal joint, exclude rheumatoid arthritis. In a sense, if the patient says I have a hand pain, if you squeeze the metacarpophalangeal joints and if you find that there is a pain or tenderness, look for a possibility of rheumatoid arthritis. In a sense, that's the extent to which there is a recommendation which is going on, but we have to wait and see how best we need to implement these things. And we need to push ahead with reference to the health policy makers, including insurance and reimbursement agencies, that autoimmune disease should be taken seriously and need to be treated and addressed aggressively. So the whole theme or the scheme in which I thought today's discussion should go ahead was in catch early, treat early, and probably what I always feel is timing and action matters when it comes to the results. So what we need is identify it early, pick out the diagnosis early, and try to treat it at the early. So where the timing, and the action from both physician and patients matters in achieving a good remission and outcome with reference to autoimmune disease. Thank you.